Thanks so much, Ben. Thanks for having me. Let me just share the slides here. And there we go. Okay, well, hello to everybody. And there we go. Okay, well, hello, everybody. And, I think that there is so much that we can all do to make Alzheimer's a rare disease, which is exactly what it should be. It should not be the incredibly common disease it is today. It will kill, of the currently living Americans, unfortunately, it will kill about 45 times as many as the pandemic. We're over 1 million now with the pandemic in the US, and we're looking at about 45 million of the currently living Americans, unfortunately, unless we do something about this. And we've now trained over 2,000 physicians in 10 different countries and all over the US. Some of them are getting really fantastic results. And in fact, in our trial with Dr. Hathaway and Dr. Gordon and Dr. Toops, really fantastic physicians, 84% of the people improve their scores. And on the other hand, there are other physicians who are not getting very many people to improve. So I thought it would be very helpful to talk about achieving best outcomes. What does it actually take? How do you do troubleshooting? What are the critical features to get the best outcomes? Because of course, when someone comes to you with cognitive decline, one of two things will happen. Either you will make them better or they will die, unfortunately, because Alzheimer's disease is unfortunately a terminal illness. And until recently, there really hasn't been anything, as people have said many times, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. Well, as I'll show you, we now have many of them. And the longest now are people that started in 2012. We first began this protocol, and so they're now a decade into this and still doing very well. So the idea is that when you're actually addressing the things that are causing the decline, then people can sustain their improvement. Whereas with a drug, if you get any bump at all, you're going to go right back down to declining because you're not attacking the root cause of the problem. So first of all, it's helpful to know what type of Alzheimer's. There are people where it's more inflammatory, people where it's more atrophic, et cetera. And of course, many have combinations, but it's a good idea to get an idea when you first see the patient, is this person's Alzheimer's mostly, or their pre-Alzheimer's, hopefully, because we like to get them as early as possible, as I'll talk about in a minute. So is this mostly an inflammatory problem? So we call this type 1 or inflammatory Alzheimer's. People with infections, often chronic undiagnosed infections, with leaky gut, sometimes with autoimmunity. Is this more a type 2? These people look very different. The type 1 is kind of your typical person, literally, typically it's in their late 60s. They've got this ongoing inflammatory process, often with leaky gut, et cetera. The type 2 atrophic people, this is typically someone who's in their mid 70s, that just doesn't have hormones, just doesn't have trophic factors, and often is decreased in their nutrients. So they often present somewhat differently. And then glycotoxic, we call this type 1.5 because it actually has features of both. It has the inflammatory feature because of the non-enzymatic glycation of proteins, which of course we measure as hemoglobin A1C. But of course, hundreds and hundreds of proteins are glycated, so they don't work as well and they are more pro-inflammatory. On the other hand, it also has insulin resistance, and therefore the insulin doesn't exert the trophic activity that it usually exerts on brain cells, and therefore they also have an atrophic picture. So they have some of both, and we call this type 1.5. And then type 3 is toxic, and this can be from inorganics, metals, air pollution, things like this, can be from organics, things like benzene, glyphosate, and things like that, or it can be from biotoxins, trichothecenes, and things like that. And then, okay, there we go. Type 4 is vascular. Typically, these people have reduced cerebral blood flow and often can have a mixed picture of a vascular dementia and Alzheimer's. But in fact, vascular abnormalities are common in Alzheimer's disease. And so therefore, you want to include going after those things. And then finally, traumatic. And in fact, there was an interesting paper by Dr. Gareth Roberts, a classic paper many years ago, showing that when people had severe car accidents, and actually passed away within 10 days, they had massive amounts of amyloid within their brain. So in fact, amyloid is a relatively early response to trauma. Over time, that may be cleared and you're left with a tauopathy, which we refer to as chronic traumatic encephalopathy. But the idea is the same, that you can get with repeated head injury an increase in Alzheimer's disease. Now, it's important to point out that one of the biggest problems today is that we have something called mild cognitive impairment. And so doctors will often see their patients say, don't worry, it's just mild cognitive impairment. Come back next year, we'll see how you're doing. So this is like telling someone that they have mildly metastatic cancer. It's actually a relatively late stage of Alzheimer's disease pathophysiology. So we'd really like to get to people before this, because you go through 4 phases when you develop Alzheimer's. Phase 1, no symptoms at all, but if you do spinal fluid analysis or PET scans, you can actually show that people already have begun on the pathway to Alzheimer's disease. So what we used to think of as a disease of our 60s, 70s, 80s, 90s is really a disease of our 30s, 40s, 50s, and 60s, which is diagnosed typically 20 years after the pathophysiology begins. So the better we can do at getting people to come in early, getting on active prevention for anyone who's 45 years of age or older. If someone is at late stage in the nursing home, please get all the children to come in, get evaluated, and get on active prevention. If you don't do that, then at least as the first symptoms appear, don't wait. Unfortunately, doctors often tell their patients, that's just normal aging, don't worry about it, right up until the point that they tell them, oh, guess what, it is Alzheimer's and there's nothing I can do about it. Now, if you don't get on active prevention and you enter this phase 2, SCI, subjective cognitive impairment, this actually lasts about 10 years. So you can see that, in fact, we have a huge window of opportunity, both in phase 1 and phase 2. And what we see repeatedly is that nobody who gets on active prevention and does the right thing actually progresses to dementia. So it's highly effective if you do the right thing. Furthermore, virtually everyone with SCI can return to their baseline. So this is very effective. It's the 3rd and 4th steps that are tough. Now, by definition, what SCI means is you have cognitive symptoms. Often your spouse will notice it. Often your coworkers may notice it, but you're still testing in the normal range. But this is relatively common and something that we can all deal with very effectively. Now, you can see then that the 3rd stage, which really should be called advanced Alzheimer's disease, because it's the 3rd of 4 stages, is unfortunately labeled mild cognitive impairment. Well, as one patient said, there's nothing mild about it. At this point, you've gone so far that you're already testing in the abnormal range, but you still have, by definition, your activities of daily living. 5 to 10% of these people each year will convert to full dementia. And so this is, again, a late stage. And then the final stage we call Alzheimer's disease. So it's a little bit like waiting to treat diabetes until you're in diabetic ketoacidosis. It really makes no sense. You want to get people when they have insulin resistance, not when they've progressed through pre-diabetes, full diabetes, and then all the way to ketoacidosis. By definition, when you have Alzheimer's, your activities of daily living are affected. And this is typically about 20 years after the initial biochemical changes. And that's been documented by longitudinal PET scans and longitudinal spinal taps. So that this is really a disease that is unfortunately diagnosed very late, and there's a tremendous amount you can do. As I said, virtually everyone in phase 1 and phase 2 do great. Most of the people in phase 3, in our clinical trial that I talked about last time, this was in people with phase 3 and phase 4, and still 84% of those people improved. But a lot has to be done. The later you are, the more that you have to do. And it's tougher. We have seen people even with MoCA scores of 0, end-stage Alzheimer's, improve, but they don't come all the way back to a perfect score of 30. So we can get people from 18 to 30. We can get people from 0 to 9, which gives them, better ability to dress themselves, speak, etc. But we're not yet able to take people from 0, end-stage Alzheimer's, to a perfect 30. That's one of the big goals. Can we get people all the way back to perfect? Okay, so the goals of treatment and prevention are, if you look at this, Alzheimer's disease is fundamentally an insufficiency in a neuroplasticity network. So you have a network in your brain. You have this beautiful synaptic dance that is deciding, are you making synaptoblastic? Are you making and keeping synapses, or are you downsizing? Very much analogous to what happened to our country during the pandemic. When it first came out, we had an insult, SARS-CoV-2, and so we were all told shelter in place, social distancing, don't go to work, downsize, et cetera. We went into a protective downsizing mode and we ended up in a recession. That's exactly what your brain is doing when it sees these various insults. And it can be from P. gingivalis from your mouth. It can be from leaky gut. It can be from insulin resistance, all these sorts of things. And so we have to identify what is putting your brain into a protective downsizing mode. And by the way, the amyloid that we associate with Alzheimer's disease is an antimicrobial that is part of your innate immune system. So it is part of the inflammatory response. As long as you've got the ongoing insults, you're going to continue to make the amyloid, you're going to continue to downsize. So what we want to do is identify what's causing that and then address those things and then rebuild. So the beginning is we want to get people with optimal energetics. One of the most common contributors is poor support from the brain. And that can be because of poor blood flow, poor oxygenation, poor mitochondrial function, or poor substrates, ketones and glucose. For most of us, we are able to go back and forth and burn ketones or burn glucose. And we're doing that as a part of being metabolically flexible. And unfortunately, when we start developing cognitive decline, what happens is we're losing both of those. We typically have the insulin resistance from years of processed food and years of high glycemic index foods and things like that, but we're also not keto adapted. And of course, as long as your insulin remains high, you're not able to generate endogenous ketones. So in fact, it's helpful to get people into ketosis. And we recommend at the beginning, just start with exogenous ketones, at least get them that energy. These brains are starving when they come to us because of cognitive decline. So we would like to get people into ketosis, typically 1.0 to 4.0 millimolar beta hydroxybutyrate, or if you measure it with a breathalyzer, over 7 ACEs, preferably over 10. We'd like to make sure they have optimal blood flow. So there's as where things like exercise and Katsu bands and EWAD and things can be very helpful. Some people do use HBOT, which is another way to go. That doesn't give you the exercise part, obviously, but it can be, especially for people who have a vascular component or a traumatic component, it can be quite helpful for these people. Secondly, we want to make them insulin sensitive and metabolically flexible. And of course, we can do that with the help of diet, exercise, sleep, stress reduction, all these sorts of things. And then at times, we'll want to use specific supplements. Berberine can be helpful. Chromium can be helpful, making sure people have an optimal zinc. Zinc is critical for making and secreting insulin, as you know. So there are, again, numerous things you can do to get people to be insulin sensitive and ultimately metabolically flexible so that they can go back and forth. Many people will present and their HOMA-IRs will be 1.5, 2, 3. I mean, they clearly have insulin resistance. So that's part of getting best outcomes. And then trophic support. And that's 3 different things: growth factors, nerve growth factor, and BDNF and things like that. And again, there are things you can do. You can increase BDNF with exercise. You can increase BDNF with whole coffee fruit extract. You can increase nerve growth factor with Alcar, as an example. Also with Hericium erinaceus, the lion's mane, also increases NGF. So again, the armamentarium, which we've been told over the years, is zero, that there's nothing you can do for people with cognitive decline. Nothing could be further for the truth. There's a tremendous amount you can do. And understanding for each person what's actually causing their decline, you can then use your armamentarium appropriately to address those things. And then hormones. Many people will be low on thyroid, low on estradiol, low on testosterone, low on vitamin D, things like that. You can address all of these things again. And then, of course, bioidentical hormone replacement has been very helpful in cognitive decline as part of an overall program. Years ago, it was tried as a monotherapy. It didn't help very much. But again, this is part of an overall protocol. You are changing network function within the brain. So you have to identify and address the different pieces of the network function. This old-fashioned idea of we're just going to give you one drug and it's going to do everything is a kind of ridiculously naive view. And of course, I think functional medicine has addressed that point for years. And then, of course, nutrients. And I mentioned vitamin D, vitamin B12 was mentioned earlier. All of these things are critical, again, for trophic support. And then, of course, resolution of inflammation. The amyloid itself is part of the innate immune system. As long as you've got P. gingivalis, or you've got Borrelia, or you've got Babesia, or you've got things like this entering your brain, you're going to be making the amyloid to kill those. So we want to resolve it, and often using SPMs to help with the resolution, very good, but you want to remove the source. It's critical. If this is because of a leaky gut, then removing that source is going to be critical for getting best outcomes. And then, of course, treatment of pathogens. And some people will end up having Borrelia or other tick-borne illnesses. Some people will have herpes simplex. That's been associated with cognitive decline. And in fact, the treatment of herpes simplex outbreaks from a Taiwanese study was shown to reduce the likelihood of developing Alzheimer's by about 60%. So it's a pretty striking effect for people who are having outbreaks. Other herpes viruses have also been associated with Alzheimer's disease. So this is critical. And then optimization of both gut microbiome and oral and sinus microbiome. And things like dentalcidin can be very helpful. So you can check, for example, with oral DNA or myperiopath, you can check to see whether there are pathogens, because this is another association with the cognitive decline. And then detoxification from inorganics, organics, and biotoxins, as I mentioned earlier, and standard sorts of detoxification. We'll get to that in just a second here. And then stimulation. People tend to do best with some form of stimulation, whether it's brain training, whether it's light or magnetic stimulation. And again, you want to be doing this on the backbone of supporting the brain. Just like you don't want to tell someone to lift weights when they have malnutrition. Once you get them doing the right things, then you want to have some form of stimulation to get best outcomes. And then we want to improve the adaptive immune system and reduce the innate, because what happens in both COVID-19 and in Alzheimer's disease, you have the innate system outstripping the adaptive system. And of course, this is why if COVID-19, people die from cytokine storm. In Alzheimer's disease, they're dying from cytokine drizzle. So you've got a mild increase in this innate system, and the adaptive system has not been able to clear whatever it is that is the insult. And then we want to reduce the amyloid. And there are things, in fact, curcumin is one of the things that actually binds quite tightly to amyloid, and it can help remove the amyloid. But you can see that you don't want to remove the amyloid and do nothing else. The amyloid is there protecting you. So you want to do the other things and then remove the amyloid. And I think in the long run, this is where the drugs that remove amyloid are actually going to be useful. Trying to just remove the amyloid without recognizing why it's there really makes no sense. And then finally, regeneration, synaptogenesis, these things are all very, very helpful. And this is, of course, where stem cells come in to use. And again, people are testing stem cells currently for their ability to do a single thing, just to have a monotherapy of stem cells, which is a little bit like trying to rebuild the house as it's burning down. We want to put out the fire first, and then we want to continue. So we can think of this in three phases. We want to do the basics. Then we want to attack the things that we can identify as specific components that are driving the decline. And then we want to do, in phase 3, troubleshooting. We want to understand if the person's not getting better, what has been missed. And it is unfortunately complicated. The brain is a complicated organ, of course, and you're dealing with about 500 trillion synapses. You're dealing with this neuroplasticity. And so when they come to you, what happens is they're already saying, we are in a synaptoclastic mode. We are downsizing, we are destroying synapses, trying to protect our brains. So our job is to understand why that is. So phase one, basics. And I mentioned earlier, we want to get you on the appropriate diet. And typically we use a plant-rich, mildly ketogenic diet. One example is what we call KetoFlex 12-3. But you can use others. It should be plant-rich. It should be mildly ketogenic. Should have appropriate fasting periods, 12 to 16 hours. If you're ApoE4 positive, which about 2/3 of the Alzheimer's patients are, then you want to be more on the 14 to 16 hours. If you're ApoE4 negative, then you want to be more on the 12 to 14 hours. You want to achieve metabolic flexibility, and as I said earlier, get your BHB in the 1 to 4 millimolar range. And then, of course, exercise, aerobic and weight. Both of these actually complement each other. Consider Katsu. It's actually great. These are the restriction bands that you can get. Were used in the Olympics. Supports blood flow, supports improve, essentially get more bang for your exercise buck. And if there's a vascular component, consider exercise with oxygen therapy. And then sleep, very important. In a number of ways, and many people are having suboptimal sleep. Even if they don't have full-on sleep apnea, they'll often have either too little sleep, or they'll have compromised sleep with their SpO2s dropping down to 80 to 90. We've seen them even into the 70s. And there was a nice paper a few years ago, a nice study showing that if you just graph the mean SpO2 for the night versus the size of various nuclei within the brain, it's a beautiful correlation. So as your SpO2 is going down, your hippocampal volume is also going down. So we want to make sure, we'd like to get people 7 to 8 hours. We'd like to ensure that they have an adequate airway. Many cases of upper airway resistance syndrome being identified now. And for many people, it's just an airway issue. And now there's an interesting group called Vivos that has actually got a way to expand airway over about 18 months' time, which may be a good idea for people who need that. You want to ensure that there's adequate REM sleep and slow wave sleep. And then, of course, you want to check the heart rate at night, because what happens is some people will get these adrenaline rushes and they'll have their heart rates are going over. They're waking up at night. They don't know what's going on. And one of the reasons, of course, can be a poor airway, or can be the beginning of some sleep apnea or upper airway resistance. But of course, another common one is hypoglycemia. And people who are having a high carb diet, of course, will have the spikes. They get too high, but they also get too low, and they'll wake up in the middle of the night with a glucose. When they check the CGM, the glucose will be 40 or 45. So if you optimize sleep, as Dr. Matthew Walker has shown all of us, you really get much, much better outcomes. And then stress, checking your HRV, whether you like heart math, whether you like TM, whether you like something else. Dealing with the stress, this is something certainly that's critical. And we do have people where literally their cognition will wax and wane depending on their stress levels. When the stress is high, their cognition is low, and vice versa. Especially we see a hypersensitivity to stress in people who have the type 3, the toxic form of cognitive decline. And then brain training, as I mentioned earlier, some stimulation. Brain HQ, I like simply because they have the most published supportive data. But you may like other ones, that's fine. Brain HQ, typically, we use this in the trial, 30 minutes, 3 times a week is a good place to start. And a couple of good ones, Double Decision is part of Brain HQ. That one actually, data published showing a reduction in cognitive decline, a reduction in the risk for cognitive decline, even 10 years out. So it's quite an interesting effect. And then Hawkeye is another good one, which is about speed of processing. And there are others as well. And then targeted supplements. And this is, again, where your experience, where your expertise comes into play. It depends on how they present. It depends on what the dominant subtype is. You're simply trying to optimize the neurochemistry of plasticity. That's the goal. So increasing BDNF with whole coffee fruit extract, one thing that can be very helpful for people. Increasing giving them curcumin. Again, that has 2 effects. It decreases, of course, the inflammation, but it also binds to amyloid and helps reduce that. SPMs that I mentioned earlier, for people, you wouldn't necessarily need them for type 2 atrophic, but for people who are type 1 and have some inflammation, very helpful. And then again, berberine for the people who are the type 1.5 and who have some insulin resistance. Berberine can, of course, be very helpful. Same thing with Ceylon cinnamon. Pregnenolone, commonly these people are very low in multiple hormones. And pregnenolone actually is a neurosteroid, a neuroactive steroid. And then for people who are low in nitric oxide, Neo40 can be very helpful. Tend to use it a lot in people who have, for example, a vascular component. Of course, DHA, and Professor Richard Wertman from MIT has shown in beautiful studies over the years the importance of both DHA and acetylcholine, or some form of choline. He has used CDP choline. That combination supports synaptogenesis. And again, we could spend hours just going over targeted supplements. Again, the great news is knowing what's actually causing the problem and what you're addressing can allow you to use a huge armamentarium. And there are more things coming out all the time. And then some basic detox. Crucifers, sauna with Castile soap following up, high fiber, filtered water, S-acetylglutathione or liposomal glutathione or intranasal, whichever you like to use. Again, getting their basic detox going as you're in this first phase of treatment. And then healing the gut, optimizing the gut and oral microbiome, as I mentioned, and that's, if indicated, BHRT. So that gives you 6 months, and many people will improve a lot during that time. You follow them and look at their CNS vital sign scores or their MoCA scores. Also, are they subjectively improving? Now, after that, then you want to look at what specific things. Are there specific pathogens? Is there Borrelia, Babesia, Bartonella, other tick-borne illnesses? P. gingivalis, did that come out of the oral DNA test? There's an interesting question that's arisen. You may be aware of the recent trial, which unfortunately failed, but there is a company called Cordyzyme that had a hypothesis several years ago and raised many, many millions of dollars over this hypothesis that all of Alzheimer's was caused by one protease from one organism, P. gingivalis. And I think that was a little bit naive. But what they showed was when they developed a drug, which is called aduzagenstat, which is a specific inhibitor of that protease called gingipane that is produced by the P. gingivalis. In those patients that didn't have P. gingivalis, no surprise, it didn't have any impact on them, so the trial failed. However, in that subgroup that did have the P. gingivalis, now it didn't make them better and it didn't stabilize them, but what it did was it slowed their decline. So as part of an overall approach, this may be good. On the other hand, is it possible that you don't need to go to a drug? Just improving your microbiome may turn out to be just as good. And you can do that with things like dentalcidin, of course. So I think it's going to be very interesting to see, do you really need the expensive drug, which would obviously give you the advantage that this is going to get into the brain, or is it good enough just to change the oral microbiome? For whatever, it's become very clear that there is some sort of communication between the oral microbiome and the brain. And this is part of what your amyloid is doing, is to enclose these various bacteria and kill them. Then other oral pathogens, T. denticola, F. nucleatum, things like that. Is there chronic sinusitis? Fungal sinusitis, relatively common, and again can support cognitive decline, unfortunately. And then treating the identified toxins. And I think this is arguably the most difficult part of the overall protocol. Organics, inorganics, again, you can do a basic detox in even using things like IV glutathione and things like that. But the biotoxins, the entire Shoemaker protocol or Dr. Neil Nathan's approach, and there are obviously some differences between the two. This is a complicated thing to do, takes some time, but can be very, very helpful when there are biotoxins present. And then I think we're going to be seeing more and more reliance on epigenetic results. And this is turning out to be very interesting. Of course, everyone's aware of a couple of papers showing that you can actually age backwards when you look at epigenetics if you do the appropriate thing. And for example, Dr. Kara Fitzgerald published a very nice paper several months ago showing that you can actually reduce aging by about 3.2 years or so, she saw, with that specific approach, which is actually has a lot in common with the approach we're talking about for cognitive decline. And there's an interesting new test out of Germany called IGL. Some people here may have used it. I know Dr. Werner Vosloo has used it extensively. And this is a kind of a combination of some epigenetics where they're actually looking at, with the changes, do you actually see binding of specific toxins to regions of DNA? It's an interesting possibility because it can tell you, okay, here are the toxins that really do seem to be affecting the genome more than others. It's also a nice look at mitochondria, and do you have poor mitochondrial membrane potentials, for example. So the better we can get a look at what's actually driving the patient's decline, the better we can do. And again, I think going forward, not just the genetics, which groups like Intellex DNA have done a very nice job with looking at your risk, but then the epigenetics complement those because you can actually look at your progress. Are you seeing improvement in there? And are there specific things that should be addressed? And then, is there autoimmunity? Now, it's interesting. People with Alzheimer's disease typically don't have a lot of autoimmunity. It's not like MS. It's not like lupus and things and rheumatoid arthritis and things like that. Again, it's more of the innate system. They're not very good with their adaptive system. However, what's interesting is a subset of these people will have some autoimmunity. Interestingly, they tend to be the one that have a little better adaptive system. And so focusing that system helps. So the autoimmunity simply says your system is not focused enough, that you're just striking the pathogens and not your own cells, unfortunately. So improving zinc, improving magnesium, and and LDN can all be helpful. And those people, as I mentioned, with autoimmunity tend to be ones who actually progress a little more slowly. They seem to be a little more equipped overall to address, and less overall innate versus adaptive. But keep an eye out for that. So then the third piece is, now we're now in, again, this is something that's been going on for 20 years typically. And if you see them before Alzheimer's, then 10 to 20 years still, because SCI is still about 10 years. So, you're dealing with something where you're trying to turn a ship that's been going one direction for a long time. So get the basics, then get the targeted, and then finally troubleshooting. Are they doing better? Are they not doing better? Is there something that's been missed? So let's spend a couple of minutes talking about troubleshooting. So people who are saying, well, look, I've been on this now and I'm not getting better. Why is that? How long have they been on? I've heard people say after a week or two, hey, how come I'm not getting better? We have seen a few people who will begin to get better after just a few days. That's typically because they've had extreme exposure at home to things like mycotoxins, and just getting them out of the environment, getting them into some ketosis, getting them improving their metabolic status, getting them on the right diets, et cetera, getting them some sleep. Those things can begin to make changes fairly quickly. But for most people, we're talking about 3 to 6 months before you'll really start to see them getting better. And you'll have a kind of typical pattern. The first thing is the decline will slow. The second thing is it will stop. The third thing is their spouses will often say, hey, wait a minute, they did something they haven't been able to do in a while. One spouse said to me that they got into the car and they'd forgotten, oh, wait a minute, I forgot directions to get to this place. Now, this is a while ago, before people were typically using their iPhones to get to places. But the wife just simply said, oh, yeah, the wife who was on treatment said, oh, yeah, you go left here, right, left, right, right. The husband turned to her and said, you haven't been able to do that in years. So you'll hear these things, and then people start to see real improvements as you continue to optimize things. So that's the typical pattern. How well documented? Be careful. You want to make sure, is it possible that the person's cognitive changes are because of a brain tumor? Did they not get an MRI? Is it possible that it's because of frontotemporal dementia? Now, to be fair, we've seen people with Lewy body disease, and there are about 1 million Americans with Lewy body, so it's fairly common. They will respond typically very well. They typically have a type 3-like picture. They have toxin-associated cognitive decline, and they tend to do very well in this protocol. Frontotemporal dementia, we've had a few people, but it's a much less common problem, and there's a lot we still don't know about that. So it's probably going to require a modified protocol to get best outcomes. So the question is, if they're not getting better, is this really an Alzheimer related? Is this pre-Alzheimer's that you're talking about, or Alzheimer's? Or is this something that maybe is completely different that this is not really related to? This approach should do very well for Alzheimer's and pre-Alzheimer's, for Lewy body disease, for vascular dementia. We don't know yet about things like progressive supranuclear palsy. We don't know yet about corticobasal degeneration. Now, the good news is the vast majority of cases are going to be one of those three, are going to be Alzheimer's, vascular, or Lewy body. But there are those few that are going to be other, and you may have to look further to see what's going on there. Have you achieved mild ketosis? When I'm typically asked by these patients, well, I'm not doing that well. Okay, what's your ketone level? Well, I'm not doing that part. Okay, well then what are you asking about? That's part of what's critical. We need to be able to get them to be metabolically flexible, burning the glucose, and able to burn the ketones. Are they on a good fats-based diet so that they're getting appropriate support for their brain? How advanced was the process? So, in fact, people who are, of course, later and later in the process, and I always encourage people, when you're dealing with your first few people, don't start with someone who has a single-digit MoCA score. Start with someone who's got a MoCA of 23 or above. These are people that you can make better, and it really shows you, yes, they can get better, yes, they can stay better. It shows you what it takes to do that. These people who are very advanced, there's a lot more that has to be done. It's much tougher, and the outcome is less assured. And then the most common cause for not getting better is a lack of compliance. Are they working with a health coach? Are they getting the right things? Are they getting into ketosis? Are they getting the exercise? Are they metabolically flexible? Are they doing all the appropriate things? Are they optimizing their metabolic parameters? Has their homocysteine improved? And we looked at the metabolic parameters in the clinical trial we did. And interestingly, all of these parameters were statistically significantly improved. So they improved on their insulin resistance, and they improved on their homocysteine, and they're improved on their HSCRP and things like that. The second most common cause of not getting better is type 3, where the people are just severely toxic, and it takes years to get these toxins down. And then there's another one that I call the too important syndrome. These are people who say, well, look, I'm going to Europe for 3 months. I'll deal with the cognitive decline later. I'm going to take a couple of supplements. 3 months from now, I'll be back. I'll be back for a couple of days. Then I'm going to go do something else. I'm going to go do something else. You really do have to live this approach. We're changing your synaptic neurochemistry. And the idea of doing it part-time every few months is simply typically not working. And then what about nocturnal oximetry? Are you dealing with someone who's dropping into the 80s at night and just doesn't know it? And what about their oral health? Are you dealing with someone who has oral pathogens and again, doesn't know it? Well, they're going to keep making amyloid to be fighting those oral pathogens as they enter the brain. Then do you need a SIRS consultant? And as Dr. Richie Shoemaker pointed out years ago, most of these people who have the type 3 don't fit his criteria for SIRS. Some of them do, but many of them don't, but they have similar markers. Their TGF-beta1 is high, their C4a is high, their MMP9 is often high. So they have a similar response. And so you may want to talk with someone who has dealt with a lot of cases of mycotoxicity, an expert. For example, the ICI group, Mary Ackerley and her many colleagues in that group. Is there undiagnosed sleep apnea or UARS, as I mentioned earlier, low SpO2? Are they getting regular brain training? Are they just doing supplements only? A lot of people will say, oh, I'm just going to do this part. Well, they're supplementary for a reason. The key is, just as Dean Ornish found many years ago for cardiovascular disease, there's a threshold. You've got to they're in a situation where they've got demand here and supply here. We need to lower the demand and increase the supply so that this network can now kick into action again. They can once again make and keep synapses. You want to keep tweaking. Do you have continued exposure? This is another common one. People are living in moldy houses and they may do some superficial remediation, but they're still living in very moldy houses. Do they have leaky gut that's continuing, or oral pathogens? Do they have an undiagnosed chronic infection? I'll show you an example in just a moment here. Are you doing ineffective detox? So that's another one. And then are the major underlying causes? The big things that create cognitive decline are anything that's causing ongoing inflammation, trophic withdrawal, insulin resistance, toxic exposure. If you have addressed those things optimally, then they're typically doing well. And then finally, as a scientist, when I was training, I never thought it was important: behavior, purpose, joy, stress reduction. And obviously, functional medicine has made it very clear that these are powerful antidotes to chronic illness. And so getting people to have the behavior, and we've had a few people who just say, I really don't care. I don't want to do the things to get better. Recently, we had a guy who came in with clear cognitive decline, and actually his friend brought him, was working with him, put him through the standard evaluation and looked and said, okay, you've got very addressable things here, here, here. He had some clear insulin resistance. He had metabolic syndrome. He had some ongoing inflammation. And he just said, nah, this is not for me. I don't want to do these things. Just give me a medicine and I'm going to go downhill. And so you do have to have people that are really interested. We can't make people better who don't want to be better. So here's an example. First symptom: unable to calculate a tip. So this is classic. Young woman with a non-amnestic presentation. That is toxin-associated cognitive decline until proven otherwise. She was unable to write a grant. She had had a perfect storm: 4 episodes of general anesthesia, major job stress, new home, menopause, toxic site for her upbringing, a sweet tooth, dental trauma with a plate in her mouth, reduced zinc, reduced thyroid, had spinal fluid that was diagnostic for Alzheimer's, her C4A 23,000, her VCS failed, Marcon's positive, and her MoCA just continued to decline. So what do you do for these sorts of people? Here are some lessons from the patient. So here's a 55-year-old woman, severe memory loss for 2 years, mild improvement over the first 6 months. Her estradiol to progesterone ratio was greater than 500. So typically it shouldn't be that high. It should be more on the 100-ish range, or even a little less than that, 50, 100. She had marked improvement with just increasing her progesterone and getting balanced. Then after a while, she started to regress. She kept a diary of her regression. It had started immediately after changing from transvaginal to transdermal BHRT. And so her follow-up estradiol level was 0. So she had gone from hundreds down to 0. Another one here, 78-year-old female with cognitive decline for 4 years. Her MoCA score was 0, ApoE33. She was late-stage Alzheimer's disease, type 1.5 and 3. She had some initial improvement, but then she did, unfortunately, what happens to people when they try to now get into this fasting too ebulliently and too briskly. And unfortunately, again, you have to remember, this is a network insufficiency, but unfortunately, it's born of excess carbs many times. And so we're trying to be very careful here. We want to give them the fasting to get them to be insulin sensitive, but we don't want to starve them because, again, they're just starving their brain again. And this is exactly what happens with many people. So I'm always concerned when the BMI is below 20. This woman actually lost weight, developed diarrhea, declined, but she again improved when her diet was liberalized. So the goal here is to get people into being metabolically flexible, to being in ketosis, to supporting their brain without starving them. So on the one hand, yes, we like to see the fasting to help do that, but we have to be very careful about reducing the support for their brain. And here's another woman, 54-year-old, ApoE44. She's at very high risk, somewhere over 50%. In some studies, as high as 90% of people who are ApoE44, and that's 7 million Americans, will develop Alzheimer's disease. So she was developing it in her late 40s, early 50s. She did very well initially, went from 35th to the 98th percentile with her cognitive testing. However, after a number of years, she began to note some backsliding. What was this? So the question was, is there something that's been missed? Further evaluation at that time found that she had very high TGF-beta-1 and C4A. So again, suggestive that she had either a tick-borne illness or mycotoxin exposure. She turned out to have babesia. And actually, Dr. Sunja Schweig saw her and has done very well. She improved once again. She's been stable for 3 years now. So the features that are associated with a positive outcome, first of all, MoCA scores of 18 or above. So again, when you get people who have SCI or MCI, and 18 is now actually even past MCI and even into early Alzheimer's disease. SCI, we can get virtually 100% of the people will return to normal. MCI, most of them. So if they've got MoCA scores of 18 or above, that's a good thing in general. Now, to be fair, as I said earlier, we've had people who are lower that can come up as well. But second thing is, if they have clearly addressable metabolic abnormalities that you can identify, if you find that they have some degree of inflammation, poor methylation with high homocysteine, low B12, low vitamin D, all these sorts of things, typically you can address these, they can get better. And then working with a health coach and supportive family. Again and again, this turns out to be very, very helpful. A positive attitude and good compliance. Again, very, very helpful in this. Continued optimization. Don't give up after the first few months. Keep tweaking. And then getting people into ketosis. And typically what we suggest is just start with some exogenous, you've got a starving brain there. Help them out. Over time, there are some advantages, of course, into getting into endogenous ketosis. But at the beginning, you're just concerned about the fact that this is an energy deficit. And then, as I mentioned earlier, the people who are of severe toxicity are really tough to improve. So a lack of severe toxicity associated with positive outcomes. And then again, so symptoms for less than 5 years. We have had people where 15 years of symptoms, but when you get people who are really advanced and they've been going on for 10 or 15 years and they've failed a number of drug trials and things like that, it is harder and progressively more difficult because they have fewer and fewer synapses that you're dealing with. And then improvement in metabolic markers. As I mentioned in the trial, we saw that people improve their metabolic markers in association with improvement in their cognition. Now, on the other hand, features that are associated with continued decline, so you really have to double down. Poor compliance, lack of interest. Again, if people don't want to get better, it is difficult to make them better. As I mentioned, severe toxicity, continued exposure. One of the most common problems is that people live in a house where there is a lot of mycotoxin exposure. They may have some remediation or not. And in the trial, one of the few people who didn't improve was because she just said, yes, I see, I got lots of mycotoxins in my house. I'm not going to do anything about it. So no surprise, she did not improve. But people will have some superficial remediation and then just have continued exposure. And as all the experts on SIRS will tell us, continued exposure is the biggest problem. Until you remove that exposure, it's very tough to get improvements. And then, no surprise, single-digit MoCA scores. Again, some of these people do improve, but it is tougher and tougher as they get down into the single digits. We published a paper just a few months ago with Dr. Ramohan Rao showing that we did have statistically significant improvements in people with MoCA scores over 10. But although there was a trend toward improvement in the people that were less than 10, it did not reach statistical significance. So it is tougher with the single-digit MoCA scores. Now, having said that, I should mention I got a nasty letter from a husband who said, how dare you tell people that it's tougher when people are farther along? He said, my wife has a MoCA score of 0, and she has clearly improved. So that's great to hear that she's improved, but that's not the rule. That's the exception. And then lack of support from family and health coach. Often what we see is the family doesn't believe it. They don't think that there could be any improvement. They take them to an expert who says, no, there's nothing you can do about this. Go on a drug and die. It's very sad to see this. You really need to get it. And I should say that's one of the, poly MDs is another one of the problems they take at doctor shopping. One to the S, everyone's got something different and they really don't do any of the things that are the right things. And then importantly, for all of us, failure to identify the key contributors. If there are key contributors that we don't know about, then of course we're not able to address them and get best outcomes. And a great example was the one I just showed who had the babesia. And in her case, she had had a tick bite 10 years earlier. had had Borrelia that was treated successfully. But she probably therefore had Babesia, because over 50% of the people who have Lyme disease, of course, do have co-infections. So she was probably harboring this Babesia for over 10 years, and it was contributing to the problem. She initially did very well, but ultimately it was bringing her down. So treating that actually helped her. So you've got to identify the key contributors, be they toxins, be they pathogens, be they hypoxia, things like that. And again, as I mentioned, there are some surprising responses, like the guy who wrote to me. But in general, it is tougher to get good outcomes when you have these very, very low MoCA scores. So these are some of the things that are absolutely critical. And I should point out, if you compare what people are getting using this sort of a functional medicine or precision medicine sort of approach compared to the drugs, here's what you see. It's quite striking. So what's being argued right now is that in one trial at one dose only, there was a 22% slowing with this aducanumab. Now that is a drug that has side effects of microhemorrhages in the brain, brain edema, and costs. And the initial cost was $56,000 every year, plus costs for infusions and MRIs and so forth. So we're looking at close to $100,000 a year. Now, the group that is marketing this drug has come down, but it's still going to cost somewhere around $50,000 per year. And if you can believe it, here's this thing that may do nothing or may do something minimal, does not make people better. The company is now claiming that they're thinking about suing the Medicare to force Medicare to pay billions of dollars, and of course, raise Medicare rates for everyone. It's already gone up because of this drug, and to force Medicare to pay billions for something that really doesn't work. It's actually, the Sackler family is more principled than that, I think, in some ways. So it's really been very sad to see this. On the other hand, the trial that I mentioned, which is publicly available, you can see it on medRxiv. This trial it improved people as opposed to just slowing their decline. So again, with the functional medicine approach, you can do so much better. And we really should all work together to reduce the global burden of dementia, getting people to come in earlier, getting them on optimized protocols, and keeping this. And I've published a number of books on this, so more detail in the books. And this is one of my favorite quotes, and this is actually from a Rabbi Tarfon, who said, "You're not expected to complete your life's work during your lifetime, neither are you excused from it." And I think it's up to all of us to continue to improve, to continue to learn. We are always learning about better and better outcomes. I look forward to the day when all of these neurodegenerative illnesses are simply things that are relatively easy to deal with. So with that, let me thank Ben for the introduction, and thank Stephen Shore once again for the invitation. Let me stop sharing there, and I'm happy to take some questions if there are questions.
Thank you so much, Dr. Bredesen. Just so thorough as always. We really appreciate this. Yes, absolutely. We'd love to jump into some Q&A. And before we do, I want to make sure everybody knows, again, the best place to find your book. Where should they go?
You can get it on Amazon. You can get it at Barnes and Noble. You can get it, wherever books are sold. Basically, very easy to get. And this last one, First Survivors of Alzheimer's, goes through 7 different people who wrote their own first-person stories and also updates on the protocol. But I have to say, it really did my heart good, starting to see these emails from people talking about the improvements, and also from the physicians. One of the physicians wrote to me and said, when the first patient came back and was clearly better, the physician started to cry. So it was just, it's so wonderful to see people who have what has been a terminal illness starting to improve, and not just subjectively, but also objectively, both of those, and getting back with their families again. So these are wonderful stories from these 7 people.
Sensational. Thank you very much for that. And Dr. Bredesen, just want to make sure everybody on our end knows exactly how to ask questions. We normally don't take chat, so we ask them to actually raise their hand. So for anybody out there not sure how to raise your hand, all you need to do is you look at your your tabs on your Zoom window. One of those tabs is called your Reactions tab. Click on your Reactions tab, and you'll see a little function that says raise hand. Click on raise hand. We'll see your raised hand. I'll call you by your first name, and I'll unmute you. And so with that, I see a few raised hands already, and I guess we'll get moving. And so we are going to unmute Sophia. Welcome, Sophia.
Thank you so much, Ben. Thank you, Doctor. I have two questions about herpes and sinusitis. Please, you alluded to herpes treatment. Could you be
Sophia, I'm happy to answer your question, but you're going in and out here. Can you say that again?
Sorry, about herpes.
Herpes, okay. Yeah, so there are multiple herpes family viruses, and it is interesting. As you know, herpes family virus is HB6A. And so there's a lot of work showing that the dominant virus family that is associated with cognitive decline and ultimately with Alzheimer's is the herpes virus family. So we always are careful to look at titers to the different herpes family members, including EBV, CMV, HVZ, HSV1, HHV6, all of those. And to address those, and I mentioned earlier, the Taiwan study showed that treating outbreaks very helpful. Now, of course, some of these other family members don't respond very well to things like valacyclovir. But again, resilience helpful, and also things like transfer factor plasmic and in some cases, fulvic acid, humic acid. These things can all be helpful, again, as part of your armamentarium to deal with this particular family that unfortunately likes the brain.
Thank you very much. And I think Sophia had an extra question.
The second question.
Yes, please. Thank you. About chronic sinusitis, is there a natural approach to treating it?
This is a great point. And again, this is a field unto itself. And as you probably know, Dr. Dennis, an ENT surgeon from Atlanta, has really made a specialty of dealing with chronic sinusitis, often associated with molds, often associated with cognitive decline. So, we have some people who have these that are bacterial, some that are fungal. So when you're doing the evaluations, you want to make sure to include, looking for mold species as well as just looking for Marcons. Of course, Richie Shoemaker has used the Marcons approach, especially looking for biofilms. And of course, the latest in all this saga is people who have COVID-19. And of course, the same sort of thing where they're getting infections. They're often developing anosmia, and of course, they are developing brain fog. And so we recommend anybody who has had COVID-19, especially if you've had any brain fog with it, or if you've lost your sense of smell with it, please get on active prevention, because you are likely to be at increased risk. And we don't have enough data yet, but everything so far supports the idea that you are going to be at increased risk for cognitive decline in the future. So just as you would say to someone, for example, who has a history of Alzheimer's in their family, or just as you'd say to someone who has a history of head trauma, please, if you've had COVID-19, please get on active prevention.
Thank you very much for that. And let's go now to Monty. And welcome, Monty.
Thank you very much, Doctor, from Ontario. So you spoke of berberine, coffeeberry, and Ceylon cinnamon. Can you expand on it a little more for me? And I read that there's a form of berberine called dihydroberberine. Is it any different from the normal berberine?
It's a good point. I have not used dihydroberberine. It's a good question. And I know, people have used all sorts of approaches. And again, we think in terms of what is the synaptic neurochemistry we're trying to get. And that includes your systemic status with your insulin sensitivity. So we tend to use berberine in people who aren't able to get their HOMA-IR and aren't able to get their hemoglobin A1C down to optimal. We'd like to see you down, 5.0, 5.1, 4.9. If they're typically hanging out in the pre-diabetic range, 5.7, 5.8, we'd like to get that down with diet, with exercise, with sleep, with stress reduction, all of these things. Even things like katsu bands that can be helpful. But for those who aren't able to do that, then we start thinking about, okay, we could add some cinnamon, for example. With the whole coffee fruit, we're thinking more in terms of increasing BDNF. This is not so much about glucose control. But of course, high fiber diets, so much you can do for glucose control. And of course, Mark Hyman has talked about this extensively. Some people like to use NACs. I mean, there are all sorts of things. Lipoic acid can be helpful. Getting your magnesium optimized, getting your zinc optimized, huge. Now, the one concern I have with things like metformin and berberine, and they have somewhat similar activities, they have a little bit of an uncoupling effect. And so there's a metformin study that showed long-term use was associated with increased risk for Parkinson's disease and Alzheimer's disease. Luckily, that was only one study. But therefore, we try, as with everything in functional medicine, to be physiological, upstream, natural, and staying away from drugs and things like that. So I would use berberine and metformin as some of the later things, but early on, there's a tremendous amount you can do to get the person to be insulin sensitive and to get them to have normoglycemia.
Thanks very much, Dr. Bredesen. And up next, we have Elaine. Welcome.
Yes, hi. I was wondering if you could describe the exercise with oxygen protocol in a little more detail. Is it interval training with oxygen on the exertion, et cetera? And where can we go to find those?
It's a great point, and there are a number of these, and I don't work for these various companies. LiveO2, we're always looking for what's the best outcome. I think LiveO2 has done a nice job, but there are others as well. And with LiveO2, what they've done it fits very well with what was reported a few months ago by the Israeli group that has had good results with HBOT. Instead, they're using a different approach. The idea is you want to run the oxygen up first. And in this case, I like it because you're actually improving the blood flow as well, which is why I like EWOT. It's also less expensive than HBOT, which is nice. So the first thing is you're running the oxygen up. So you're now taking areas that have not gotten the support that they need. But now you're cycling. And so what LiveO2 does is cycle you into a relative, you want to be very mild, but a relative hypoxia, which now stimulates the production of trophic support. So you're kind of getting the best of both worlds, which again was pointed out by the Israeli group. They do the same thing. They do these 5-minute hypoxic cycles and then back into hyperoxia again. So that, I think, especially for people where blood flow is an issue, where vascular component is an issue, where oxygenation is an issue, can be very, very helpful. And I would add for people with histories of trauma as well. So that's why I like EWOT. Now, it is, even though it's less expensive than HBOT, it is somewhat expensive. And if you're going to buy your own equipment, it's several $1,000s. But you can go, there are a number of gyms, there are a number of doctors' offices that have this as well. So I think, again, in the overall armamentarium, especially for those subtypes, it can be very helpful.
Thanks very much for that, Dr. Bredesen. And let's go now to Crystal. Welcome, Crystal. Oh, Crystal, I think I didn't mute you properly. Let's see, try that again. Oh, Crystal, I don't know if you're pressing the button, but I'm going to go ahead and unmute you. Let's see. Crystal, I'm going to try this one more time. Hi, Crystal, you there?
Yes, I am. Can you hear me?
Gotcha now.
Okay, great. Thank you so much. And Dr. Bredesen, I think your work is outstanding.
Thank you,
I appreciate all the hard work that you put into this to help people's lives improve. So kudos to you for that. Two questions, one regarding my dad. So he's turning 90 on Friday. And he has mild cognitive decline.
Okay.
He has peripheral artery disease, so he's a very difficult time walking.
Yeah.
His legs are very weak. He has to rely on the walker all the time. So I've tried to do things and he's eaten carbohydrates his whole life.
Right.
Cereal.
As most of us have.
Yeah.
As most of us Americans have.
Right. So been trying over the years off and on to get him to switch up a little bit in terms of not always having like the cereal for breakfast and eating so much bread like a sandwich. He thinks he needs to have a sandwich for lunch, but that's marketing because we've been programmed to think that that's what we're supposed to eat. But in any event, with the amount of time he has left, I don't know, it could be 10 years, it could be 10 days. We don't know when you're 90. But just trying to look at some options for him. I did buy some berberine because I suspected that his blood sugar levels were elevated because he had passed out one time and went to the hospital, and they said that his blood glucose level was high, but that he was not diabetic.
No.
But I don't know if that's true or not. But either way, I did try, I am trying to cut back on his carbohydrates and things like that. So just trying to get an understanding if there's any specific testing that I can maybe request when he goes to see, I don't know, a neurologist or something.
Yeah, so you have to take him to the right neurologist, because a lot of neurologists will simply say, oh, this person has MCI, we're going to give him Aricept, which doesn't really, it doesn't change the underlying problem. But again, you're basically talking about a tune-up here. There is so much that you can do because, as you're pointing out, most of us have been doing the wrong things, eating cereals for breakfast our whole lives, eating too many carbs, having high blood sugar. And you mentioned some vascular disease. There is so much that you can do. To begin with, just getting him some improvements on day one, you could consider some exogenous ketones. If I don't know what his cholesterol status is, but you probably want to stay away from MCT oil only because of the potential effect on lipid status. But getting some ketone salts or ketone esters or a combination of those, that will boost the support. Now exercise, you can do exercise without getting up and running around. There are all sorts of, the arm exercises and core exercises that can be done. So that could be helpful to him. And as far as evaluation, yes, and we developed something called Recode. You can look at so-called Recode report. You want to know the basics that are driving this problem. And you've already described several of them, things like cerebral blood flow changes. I don't know what is happening to his oxygenation at night. You can function as his health coach, or you can get him a health coach and really start working with them to optimize these various parameters and get this whole system working again, working together. He's a very strong guy. He's 90 years old. And yet, as you said, he's been doing a lot of things wrong. Imagine that he starts doing those things right now. He may do well for, as you said, for 10 or more years, 10 or more additional years. So yeah, there's a lot you can do for him. And yes, you want to know the very parameters. If you take a look, for example, at any of those 3 books, it goes through, here are the tests that you want, and here are the actual places that these tests should be.
Thanks very much, Doctor. And Crystal, thanks for your note. I know you have another question. Go right ahead.
Oh, okay. Well, the second question, thank you so much, was how would I go about getting the right kind of test to find out if I am ApoE positive, negative, or one gene, 1 copy, 2 copies? Is there a specific test that I need to request?
Yeah, and you can go on mycognoscopy.com and you can get this whole set of tests. If you just want to know your ApoE status, you can do that with 23andMe, for example. That's one easy way to do it. But that will that'll tell you your genetics, but it doesn't tell you any of your biochemical concerns. So doing those, doing either one of those things, easy to do. Or you can ask your doctor, who can also order these things.
Okay, thank you very much.
Thanks, Doctor. Thanks, Crystal. And let's go on now to Rebecca. Hi, Rebecca.
Hi, thank you. Could you repeat what you were talking about if you had COVID-19 the things that you should be doing? Did you mean that for everyone, or were you talking about people who already are having some cognitive decline?
Yeah, that's a good point. What I was saying is, because COVID is so often associated with some brain fog, and because all of the data so far support the view that it will likely be a risk factor for future cognitive decline. Therefore, what I was saying is anyone who has had COVID should go on active prevention for cognitive decline. Now, especially those who had any brain fog with the COVID or brain fog after the COVID, or has long COVID, long haulers, any of those things, or has a family history of cognitive decline. But in general, anyone who's had COVID, again, because we don't know everything yet, the pathology is suggesting that COVID does affect the brain in multiple ways. It impacts the vasculature. It can give you microinfarcts. It has autoimmune features. It can give you, again, immune disruption as well. It can infect, and there's a controversy about whether there's direct infection of the brain. Clearly there is for the endothelial cells. So for multiple reasons, I think it's a very good idea. Hedge your bets, get on active prevention if you've had COVID, and help to reduce the likelihood that you'll have long-term cognitive problems, in which COVID was one of the risk factors.
Thanks very much for that, Dr. Bredesen. At the moment, we don't have any other questions. I've got a few questions, if that's okay. And if anybody else wants to raise their hand, go ahead and click on your reactions tab and click on the raise hand function from there. And before I get to my question, looks like Sophia has another one. Let's jump right in. Welcome back, Sophia.
Thank you so much, Ben. Please, doctor, for the katsu, there are some bands, and also there are another type of katsu, like with a machine. I wonder which one you are really.
Yeah, it's a great point. Katsu bands tend to be a little more expensive, and it's, you can certainly get, it's simply blood flow restriction bands, and you can get these for about $30, $35. So you don't really have to pay more than that. And you don't want to make them so tight that you're literally not allowing blood to flow. So it's just slight restriction, which is basically telling your muscles, okay, work to get increased flow again. So it gives you kind of, more bang for your exercise buck.
Thanks very much for that, doctor. And now let's go to Monty is back with a follow-up. Hi, Monty.
Yes. Is coffee berry safe for normal use? Like, let's say you want to build your BDNF. Is it safe for normal use, and how is it best to source it?
Yeah, it's a great point. Neurofactor is the group that actually developed this. And of course, a lot of people have gotten interested in it. It's in a lot of different things now. It is, so you can source it. The ultimate source is typically from Neurofactor. Or the neurofactor from the specific the group that developed Neurofactor, and you're right. What they found was they've looked at different dosages, they've looked at different timings. So either 100 milligrams or 200 milligrams, and they've gone back and forth about which is preferable. And they've also looked at when to take it. And they initially found results taking at night. The answer is you could probably take 100 milligrams or 200 milligrams anytime. But the best results seem to be so far with earlier in the day. It does impact people, no surprise. People who are low on their BDNF seem to do better. The people who already have optimal BDNF, of course, don't get as much impact of this. So you could potentially check your BDNF. I think ZRT is the one that will look at BDNF levels, and you can see whether yours is on the low side. Again, exercising, another way to bring up your BDNF. There's a lot of interesting neurochemistry around the close relationships between BDNF, its receptor, which is TrkB bound to P75, APP itself, amyloid production. So these things are all interrelated, and BDNF clearly is an important part, with higher levels being inhibitory of Alzheimer's and lower levels being associated with Alzheimer's disease.
Thanks, Dr. Bredesen. And up next, we are bringing in Debbie. Hi, Debbie.
Hi, thank you for having me. And I really enjoyed your talk. Thank you, Dr. Dale. I'm from Australia, so it's just gone 6:30 in the morning.
Yeah.
But it's been...
Thank you for getting up with us.
Oh, no, it's been really good, really good. And I wanted to ask a question, if I may. We've got a a very old medical device, which is today recognized as cold air plasma. Have you used that kind of technology at all in the clinic?
Cold air plasma. Well, first of all, let me just say thank you for getting up from Australia. And I have to say, when we first started this protocol and we started training various people, we had a tremendous response from multiple Australian physicians. I think when I visited there, Australia, I have to give credit, been really ahead of the curve on a lot of functional medicine and doing a great job. So congratulations to the physicians and practitioners there. However, recently I got an interesting set of emails from the group that's interested in having your NHS recognize that there is mycotoxin-related illness, including cognitive decline. And surprisingly to me, the NHS has really dug their heels in and not recognized that there is such a thing as mycotoxin illness. So this is unfortunate. And I think we're all dealing with this here in the States as well. There's a question about, do mycotoxins really cause illness? When, of course, the data suggests absolutely. Now, as far as cold air plasma, please tell me a little bit more about it. I don't know cold air plasma.
What the medical device does is it uses physics, pulsed electromagnetic fields, and or quantum physics, pulsed electromagnetic fields, and cold air plasma. And the plasma is smaller than the oxygen than gas molecules. If you consider the aurora lights above the northern hemisphere, the beautiful green glow you see in the sky, it's full of reactive oxygen and nitrogen species. Right. So we produce that same, we manufacture that same cloud, that type of oxygen that's not readily available in our environment. And it's not necessarily negative or positively charged, but neutral. So the reason I'm bringing it up is what we've found in practical results. It's been very helpful in Wuhan, and it's also been very helpful with long haul COVID. But it's only one piece of the puzzle. And I find to help more people with brain fog, we need more than that. But we are getting reports of improvement within 8 weeks and in anosmia within 6 weeks. But we'd be interested to collaborate with you perhaps and maybe send you a device and see what you think.
I'd love to talk further. And so here's the thing about this sort of approach. So I understand that this sort of approach you're talking about, and I would say it's a distant cousin of ozone therapy. What you're doing is, as you said, you're actually creating reactive species, in this case, physically. And these things have two effects. And it makes perfect sense that you're dealing with things like COVID, where you have an organism as well as a response, but you have a second response, which is a hormetic response. So having these things on board does give you a mild insult, which now you respond to. So and I would agree completely with what you said. You want, for optimal approaches, to have more than just that. So you want to have people have the appropriate, for example, glutathione level, have the appropriate ascorbate level, have the appropriate, resilience, all these sorts of things. And again, this is a new era of medicine. The old era of medicine was we write you a prescription, we ignore everything else, and usually you die. Great for simple things like pneumococcal pneumonia, not good for neurodegenerative disease. The new era of medicine is humans are complicated organisms, and you're tweaking all of these different network functions. And what you're describing is one of the ways to deal with that. And it's have you looked at the antiviral effects? Because I would assume that what you're doing does indeed have antiviral effects.
Yes, it does. Since 1967, we have 97% of our patients. Independent study was done by University of New South Wales. And it showed that they get much less severe and less frequency of colds and flu. So we do know we're having an antiviral, antibacterial, and it's a very weak application. So it's shown that there hasn't been any side effects. We haven't had any recalls in 55 years, but we've pretty much only kept it in Australia. So we've never really taken it further. And I think that's because we haven't been linked with people with the expertise as yourself.
I'd love to hear more about it. So let's follow up.
Okay, thank you.
Thank you very much.
Thank you so much. And And so it looks like that those are all the questions that we have.
Excuse me.
God bless you. And
Okay.
I believe that you are you need to get moving a little bit early as well. Is that
right? And I've got a 1:30, so I need to run in just a couple of minutes, but happy to take any questions until then. And thank you very much. Fantastic questions. And again, there's so much that can be done. I think everyone working together, we really can reduce the global burden of dementia. And of course, that is the goal. This has been the area of greatest biomedical failure when it comes to therapeutics, whether you're talking about ALS or frontotemporal dementia or Lewy body disease or Alzheimer's disease. We all, I think, can do better by addressing the actual causes of the problem. So I appreciate the real truth that's really, getting behind what is causing these diseases. And I think we can all do a much better job than simply these prescriptions that have been ineffective. So thanks again. Thank you, Ben. Thanks to Stephen, and thanks to Real Truth and all the participants. And I look forward to seeing you again.
Dr. Bredesen, the privilege is all ours. We really appreciate it, and we really, really do. So thanks for coming back again. In fact, I'm going to ask our tech team to unmute our entire audience because I know they want to thank you as well. What does everybody want to say to Dr. Dale Bredesen?
Awesome.
Thank you.
Awesome, Dr. Dale.
Thank you so much.
Awesome. Thank you.